Welcome to Endo Battery, where we are sharing our endometriosis journey and learning along the way. This podcast is in no way meant to diagnose or give medical advice, but a place where you can gain knowledge and information that can help you to not feel alone as well as become your best advocate. We want to learn with you and support you wherever you are in your journey.
Thanks for joining us. I'm Shelby.
And I'm Alana, and we're Endo Battery.
Charging our life when endo drains us.
Sure, honey.
Welcome back, and we have Nancy Petersen here again, and we have been having a riveting conversation because this is something that is so deep and there's a lot to it, and so we're going to continue just talking about how this is affecting us. And Nancy, we had some questions from some of our followers, and I know one of the questions that they had, we've talked about how it's only found really the last thing you had talked about is that it's not often found in where we think it is. It's more like the ligaments and things like that. Those are the more predominant places it's found. However, we don't often talk about the ovaries of this and how much they play into this disease. I mean, it not only plays fertility, but it plays with our hormones. It plays with everything else on top of that. And I know for me personally, having had a total hysterectomy, I have had a really hard time figuring out this hormone business. How, in your experience, how has this affected a lot of the women in the endometriosis community? Because I feel like this is one that we don't often talk about as post-surgery as much.
There's several things that come to my mind when you talk about ovaries. First of all, if there's a long history of one cyst rupturing after another and of endometriomas, which are a little bit more important than the average ovarian cyst, the doctor may recommend removal of the ovaries. The American gynecological groups, both AAGL, American Association of Gynecological Laparoscopists, and ACOG, the American College of Obstetrics and Gynecology, have position statements that normal ovaries should be left alone. They should not be removed. Mm-hmm. And forever we thought that, not we, but a lot of people thought that you should take the ovaries out because you'll reduce the estrogen. And if there's any endometriosis left, then the patient will do better, or their endometriosis will die off. Mm-hmm. That's a fallacy. That's a myth. Yep. Endometriosis makes its own estrogen.
Yep.
Cedar Brulin, who is a researcher, I think, from the Midwest, documented that, 10 years ago at least. So we've known for some time that the disease will make its own estrogen supply, and it will continue on after hysterectomy, after castration, after medical suppression. So you have to kind of think about, why are we removing ovaries at the time we do a surgery? Mm-hmm. They need to be diseased ovaries. And then if you don't remove them, then the patient will have estrogen supply for whatever the normal cycle of the ovaries are. Sometimes the ovaries will sort of sag after a surgery, and it takes a while for them to kick back in. But generally, if you have to remove ovaries because they're diseased, and you're trying to get the patient comfortable and, whatever, estrogen supplementation is good to use. Mm-hmm. The key, the thing that makes everybody nervous is that, well, it's going to make my disease worse. Well, if the disease was adequately excised in the first place, taking estrogen isn't going to be an issue.
Right.
Mm-hmm. If you take estrogen and you get more symptoms, it should be suggestive that maybe endometriosis wasn't all removed, and that needs to be revisited.
Right. Mm-hmm. What about those? We have one gal that we know that has struggled because her levels of testosterone, because your ovaries produce all your hormones. And so that it's not just estrogen that it produces.
That's right.
Progesterone, it produces testosterone. And we all need those for certain different reasons in our body, right? To get it to function correctly. After those are taken out, what are some ways, are there any studies out there that would help those navigating not just the estrogen hormonal imbalance, but also the testosterone and the progesterone imbalance, because we haven't found anything other than for males in prostate cancer as to the testosterone therapies and stuff.
Well, there are some combined supplements for progesterone and estrogen that I think people are trying. I'm not a real strong resource for that because I'm not a gynecological nurse. I'm
Right.
an endo patient who got ticked off. But there are some ways to deal with that in terms of supplementation, but a lot of people are hesitant to put patients on supplement because they're worried about what's going to happen to their endometriosis. I think Dr. DeLumba from Texas has identified that endometriosis actually has hormone receptors for both, but I don't believe there's evidence. I mean, I don't know anything about the evidence of the endometriosis producing testosterone or progesterone. I know it produces estrogen, and it's why patients can continue symptomatic on through menopause. I think our oldest patient was 74. And I've seen some in the literature as old as 80 with active endometriosis, very painful, no ovaries for 50 years, that kind of thing, you know.
Yeah.
So I'm probably not the best person to answer that question. I mostly have seen patients tolerate hormone replacement therapy when their disease has been adequately removed. And I know that physicians are talking about, combination drugs, but I'm probably not a good resource for the entire question.
Well, and that's what's tricky too, because you have such a wealth of knowledge, but we're still finding so much out. This is not a disease that they know so much about at the top of their head. Otherwise, we would benefit greatly from that, right? Because
the research is painfully low. And again, to your comments earlier on, who's doing the research is pretty important. It's the drug industry. And that's not really helpful for patients who want clear information about what's my best next step, because if you're biased toward drug therapy, that's going to be what they're going to come up with. And so that's always a concern. How do you get good information to patients?
Right.
The research isn't being done in ways that's helpful.
What do you think has been the biggest shift in the last 10 years in the endometriosis community?
The biggest shift has been, I think, in the last 5 years, in my view, my long view for 35 years or however long I've been doing this, is suddenly we've got people training doctors all around the world. And part of the problem is the strength of the trainers.
Right.
So while the information is really important and teaching doctors to do a better job is critical, who's doing the teaching is pretty important factor. But I see some really great things going on. Hassan Morosi, who's from London, has just taken a sabbatical and moved to Cairo and has established a treatment center there, and he's teaching surgeons.
Wow. Yeah.
Arnaud Watig from France, when he hit 70, they wouldn't let him do surgery anymore, so he went to Dubai, and he began training surgeons in Dubai. Yeah. And we're seeing this everywhere, that there are really good people training new people. The different centers around the country. The Cleveland Clinic, Kara King Robinson King. She was trained in the MIGS program by Ted Lee in Pittsburgh at the University of Pennsylvania Medical Center. She moved on then to Cleveland Clinic and began doing endometriosis surgery there. And she began hearing from colleagues who said, I'm not as comfortable in the OR as I would like to be. So she started a mentoring and coaching program for surgeons who completed their MIGS training but would like to feel a little better in the OR.
Mhm.
So suddenly you got people admitting, I think I could use a little help to be more confident in the OR. So I think that's an amazing program. Nash Moad from the University of Florida has just put forward a new, more aggressive MIGS program teaching a broader piece of what does endometriosis look like. There are a number of individual surgeons around the country who do fellowships. Cindy Mossbrucker in Gig Harbor, Washington, has done several fellowships with people. I think the Center for Endometriosis Care in Atlanta, they've had one fellowship after another. The Mayo Clinic in Phoenix, with Megan Wason and Javier Magrina have turned out some wonderful surgeons who better understand the disease. So that trend, I think, of teaching is just an amazing thing, and it's mushrooming. And I'm so pleased to see that, because I think long term, that's where the future lies, is helping people understand that what we know about the disease right now isn't good enough.
Yep.
And being humble enough to say, I could use some help.
Right.
The pelvic nerve and blood supply and organs and ureters and all of that is extremely complex. And if you don't do it right, there's going to be nerve injury, there's going to be ureter injury, there's going to be lots of problems. It's just complex. I'm an old neurosurgery nurse. My first job was in a neuro referral center at Good Sam in Portland. We got patients from 5 states. We have 45 beds. None of our patients went to ICU because the neurologist didn't trust it. ICU. It was so new, and we had such complex patients coming. But what I've noticed is I worked there for 5 years, and then in more recent career in endometriosis, what I've noticed is that endometriosis surgery is as complex as brain surgery and needs as much training. And we're not there yet, but we're headed there. And I think, to me, that is the most encouraging thing. I do not believe we will be completely where we need to be in my lifetime, but we're getting close. Of course, the end of my lifetime is getting close too. I wish they'd step
No, we need more Nancy. We need more Nancy. I think it's funny because you say that, but what you have done is far exceeds what most people do in their lifetime in helping thousands and thousands of people with this disease. And I think credit due to you too, because you really have pushed this forward without someone to spearhead that and get a team around them. And we've talked a lot about getting a team around you, whether that's professional, whether that's for your personal life or with the endometriosis life. Having a team surround you is key in having a fulfilling life and having the ability to sort out different key components in your life. And so your team has done phenomenal, and you've done phenomenal because of that. And I think that it's showing in a lot of ways, in the surgeons and the way this is going.
Thank you for that. One of the things that I noticed about Nook is originally, about 12 or 13 years ago, the Endometriosis Research Center and Heather Goudon, who was part of that founding of that group, asked me if I would help moderate a discussion on their web page. And they had, I don't know, 150 or 200 patients, something like that. And it got kind of unwieldy to try to do there. And so they were the ones that suggested that we open the Facebook page. So I think it was about 2012, we went to Facebook with 200 patients. Nobody envisioned that we were going to hit 170,000 patients, which we did last week.
Yeah.
And actually, the numbers are much greater because a lot of people come, get what they need, and go. So you see the numbers go up and down all week. You have 400 patients come in this week, and you're still at 170,000. You go, how did that happen? Well, 400 picked up what they wanted and left.
Right.
So thank you for that acknowledgement. Yes, Dr. Romine has been very generous with his acknowledgement of my impact on the industry, as have a number of people. When we started 12 years ago, many physicians looked at it as another Dr. Google, and they were very disrespectful about what we were doing. Now, many of the world's leading physicians send patients to us for education.
Mhm.
Because what happens is it makes that first consultation or the second consultation go much easier because the patient already comes with a boatload of information.
Yeah.
And sometimes they got a lot of tough questions to ask, and that's fine. We encourage that too.
They're humbling their skills
but-
and ability, which is
Mhm.
good.
Yeah.
Yeah, I think what happens is it makes the consultations more productive because you don't start way back at the beginning and start to explain what endometriosis is and what the symptoms are. All of that has been done. Patients have had an opportunity to learn that. And so now, I think that's probably the one thing that I take away with Nook is that we have become a resource that people trust, whether it's nurse practitioners or physical therapists or physicians. And I have to admit a little pride in that because so often things that go on the internet are so full of misinformation. And I don't know that we always get it right, but I think most of the time we do, and we are committed to evidence-based information. I notice I got a couple of patients that a patient will say something in their initial introduction, and right away I get an email and say, "Is that always true?" Catching me because I didn't nail that one piece that wasn't. No, that's not quite right.
I feel
that's
like
okay.
that's fine.
Says to me that patients are learning what they need to learn, and they're holding me accountable.
Yeah.
I said, I'm getting older. Sometimes I forget.
Right.
Well, and I also think that things are changing, and then also every body is different. We've talked about everybody, and every body is different. And I think even if research points one way, it may be different for you because your body is different, and endometriosis does not discriminate with where it goes and what it does. And so not every doctor is going to be able to, hone in on that. Not every study, I feel like, is going to be able to hone in on that. And there's so much more to learn from it. So I think that's a big part of it too, is that we're not always going to get everything right all the time for everybody.
Well, and that's one of the things that I teach patients is, if you go to a doctor that we think does good surgery and he pulls out the prescription pad and said, "I want you to take this after surgery." Part of what we teach you is what do these hormones do, and particularly the GnRH family of medications, which I think are dangerous. And so what I say to patients is if they can do good surgery, they may have a different philosophy about the use of a medication. And we teach you what we believe or what we think the evidence shows. You got your own mind to make up. It doesn't mean he's not a good surgeon.
Right.
So he may not fully. I got a message the other day that there's one doctor that doesn't really like being on the list, and it was his patients that recommended him. I said, "Well, have him get a hold of me. I'll be glad to take him up." "Well, he doesn't believe in everything that you say." I said, "Well, I don't believe in everything that all of our doctors say either. But if they're good surgeons, I'm willing to give them a little latitude."
Right.
We don't believe everything our husbands say either. So that's called wisdom.
Exactly.
I guess going back to the educational piece, we have a few listeners and followers that are, in the nursing and medical field. And, everybody's been wondering, do you think with more research coming out that hopefully in medical school or nursing school, more will get taught outside of big pharma stuff with
I'm hopeful. One of the problems is money. Big pharma puts money into all kinds of things, and medical schools are no different. And so there's that kind of tit for tat that takes place. If we give you money, we expect some respect for our work. But I think that patients are pushing that whole agenda, saying, "Wait a minute, that doesn't work." If you look at the GnRH family of drugs, I think there's somewhere between 25 and 30,000 complaints have been filed with the FDA. Some of the side effects are very serious and are lifelong. And now we're seeing in men who took Lupron, for instance, The urologists now are warning those patients, even though they're still using it for prostatic cancer, they are warning them that there is a component of increased risk of dementia, significant risk.
Interesting.
Mm-hmm.
The number of studies that have been done on women, the millions of women that have taken that drug, I call it the sounds of silence. There hasn't been any.
Mm-hmm.
Yeah.
And I think that's a shame.
Yep.
I think that's a
Agree.
shame. Yeah. So I think that over time, these issues are going to push to the surface.
Mm-hmm.
Unfortunately, they have to push to the surface to get our attention.
Right.
Yep. Yeah.
Yeah. But I think there's already some of that. But some of the programs that are, like, for instance, Nash Moat at the University of Florida, he's a professor there.
Yeah.
Many of the physicians on our list in NUC are assistant professors in different programs. And I know they're following what we're doing and what their patients are doing and how their patients are doing.
Mm-hmm.
So I think you're going to see that shift begin to occur. It probably has already occurred to some extent.
Right.
Right.
So I don't think, there's reason to be hopeful. It's just not moving as fast as I want.
Right.
As anybody
as anyone wants. Would you say that part of the hesitancy for doctors to come on board is the fact that our insurance system has kind of broken that down too much to where they're not getting paid? So people don't want to do this and put the money and energy and effort in because they're not getting paid. But how do we change that?
Yeah, that's a really good point. And I think there are several things in the works, and it may take some time. We got into this mess because there was a conscious decision to pay for OB, and the gynecology surgery wasn't all that important. And this is 25 or 30 years ago,
Right.
Mm-hmm.
So what's happened is you've got patients who need a 5-hour surgery, and physicians are getting reimbursed for 45 minutes in the OR, and you can't support your office overhead and all the rest of it with that. But recently there's been an effort to develop codes for endometriosis surgery. Right now, the codes are the same for ablation and excision.
Mm-hmm.
And so there's a move by people like Ted Lee, who was a former president of AAGL, and others. I know there are others involved in that. I just don't know who all is. To develop codes for what we're actually doing, with the idea that will cause a shift in the insurance industry eventually.
Right.
The insurance industry has gotten a free ride.
Mm-hmm.
These physicians have been doing these surgeries either for no reimbursement or inadequate reimbursement, or they've gone out of network and charged what they think they're worth.
Right.
And the patients get better, and the insurance industry benefits because the patient isn't requiring one surgery after another, one medication after another. So they've gotten a freebie for 25 or 30 years out of this whole excision movement. And I think there's a time for reckoning here, but just how quickly it will happen, I don't know. But you are exactly right. The insurance reimbursement issue is a big one. And I understand physicians saying, look, my patient will get her symptoms under control with, suppression. I can't afford to do this, case after case, 3 and 4 hours, and get reimbursed at a rate that doesn't cover my expenses. Right. So I understand that. I do understand that.
Yeah, it's a tricky one because we want people to get better, but we also don't want to, put our doctors out of business.
Mm-hmm.
Yeah. Well, that's right. And the other piece is that people are not used to having to pay the doctor's fee themselves. That's what they have insurance for.
Right.
And insurance isn't meeting that obligation. And so it's hard for patients to sometimes understand, but at the same token, you get paid. There are physicians who are in university programs and in large clinics who are salaried, and they have to do a certain level of production to earn their salary. But there's a safety in that patients don't have to pay out of pocket huge amounts of money. It's the private, practitioners that are the ones that are under the gun on this. And yes, some of them charge a lot of money, and I'm not sure, I'm not going to make any friends saying this. I'm not sure that it's necessary for some of the kinds of fees that I've seen. I think there's a way to make a decent living and not blow it through the roof.
Right.
Mm-hmm.
There's a balance there. I
Yes.
feel like there has to be a balance there at some point, right? This is so tenfold, right? There's so many different elements of this disease that we could talk on for hours because it's an invasive disease. It's an invasive topic. We have very different mindsets. The one thing that I had a question on was, do you ever feel like there will be a better gap between Eastern and Western medicine on this disease, or can there be a better gap?
When I think I was lecturing in Toronto at one time, and I had a long conversation with a person about Eastern medicine, and she was well known for her work. And I asked her about treating endometriosis, and her thoughts were that Eastern medicine doesn't offer as much as surgical excision, but it provides a lot of support in easing symptoms, in helping patients understand the disease, and the mental and physical, dietary, exercise, all of those kinds of things, meditation. The 22 or 26 years I was dealing with white hot leg pain, I spent, and this is 1970 and 80, I was spending $300 and $400 a month, which was a big chunk of my salary at that time, in things like Feldenkrais and Alexander movement and massage and acupuncture and Rolfing or structural integration, just to stay on my feet, And I had picked up a book at that time called Free Yourself from Pain, and it was written by the director of the pain clinic at UCLA. And what he did was pull together all of the kinds of things that can be used if patients can help themselves. I think the book's still in print. The last time I checked, it was. And what he found was there was no excision when he wrote the book. There was none of that going on. But what he found was that his chronic pain patients, about 85% of them, could help themselves with learning these techniques. And so it doesn't solve the pain completely. It helps with coping with pain. It helps with, getting along with your life. You still need good surgical care for your disease. But of course, at that time, I didn't know I still had endometriosis. I was just trying to stay on my feet. And I think that part of what he was offering is the kind of thing you see in Eastern medicine as well, diet, meditation, all of that. I became an avid reader of many of those tools. So yes, I think there's a marriage there that's quite possible. I think patients who look at diet and lifestyle and Eastern medicine as a curative issue are probably going to be disappointed. But as a supportive issue, I think it's critical.
Yeah, I would agree with that.
It was how I survived that 26-year period, was using those tools. I had a meditation tape that I kept with me all the time. And I took my lunch and dinner breaks. I had a little van at that time, in the van in the parking lot at the hospital. And I would lay down for 20 minutes and listen to a tape just so I could finish my shift. So yes, I think there's a value.
Yeah. Do you think there will be a better bridge between the doctors and these alternative resources?
Yeah, I think
because
so.
I feel like that hasn't been the case, not necessarily for excision specialists, but definitely OBGYNs and stuff like that. I feel like there's that tug of they don't know what they're doing. They don't, you know what I mean? And that's a whole nother topic, but I'm hoping that maybe we can get a bridge between the two of a better understanding.
I think you have to look at what helps and how can we pull all of those together. Again, I think Sally Sorrell is kind of a leader in that area. She's got her endometriosis summit going, but when she develops her agendas, she brings in all kinds of tools that patients might, and she doesn't say this is the thing to do. This is something to try. This is something to look at. I tried to teach patients way back, look at all of these different tools and decide what's working for you and get rid of the rest. You don't have to do it all. Find what helps you. And I think meditation was one thing that was extremely helpful for me to cope with what I was coping with. So yeah, I think there needs to be a marriage. We need to help people find the tools that will help them if they don't have to feel guilty. If they don't work, let go of them and move on to something else.
Yep.
Right. Absolutely.
Yeah.
I definitely utilized Eastern medicine. I went more that route the entire way with my endo journey. And so it has been nice having that as a tool. But even, my acupuncturist now, once she gets to a point with her patients, she refers them out if she feels like they're not having the quality of life that they deserve. And so that's been cool to see that transition of, finding the support the best way that you can do as a patient and as well as a practitioner helping those patients. But then, once you get to a dead end or you just don't feel like you are the person to best support them, to refer them out, which has been nice to
I
see.
think that's critical, that you look at what works and what I'm doing for patients. Is that helpful? Yeah. Well, no, not quite so much anymore. So who else can we add to this
Right.
this tool
Right.
bag to help this
Mhm.
patient feel better?
Mhm.
I've said to physicians who kind of get on me sometimes, a lot of people after me. You may have noticed there's some pretty nasty websites after me. But I always say to physicians, somebody said to me the other day, how do you put up with all that? And I said, well, I saw somebody send one of those images around not very long ago that how do you sleep at night when people hate you? And the answer was with the fan on.
Right.
That's kind of how I feel about that. But
Yeah. But the flip side is you are, and you're giving all these people tools to put in their tool belt. And that's really why we're doing this podcast, is to give multiple tools. We don't know the end all be all, but we will help you with some tools to help you get through this and not feel so isolated like many people do with this disease. And so for you to come on and say the same thing is like,
Reassuring.
it's reassuring to us because this is so valuable.
You have to use what's available, what helps you. I've
Right.
said to physicians over and over, 2 points about this. A patient said to me, Nancy, I don't know what to do next. And I said, what's the issue? And she said, the issue is that I went into the doctor's office and she said, I have 2 little toddlers and I'm in agony. I can't even bond with my kids. I am spending most of my time on the couch. And I said, well, what does your physician say about this? And she said, well, he looked me right in the face and said, I don't think you were pregnant long enough. You should have another baby.
No.
And I said, and you said, she said, I just got up and walked out. I didn't say anything. And I said, okay, your next move is to find another doctor.
Yep.
You need to find another doctor.
It just makes you so mad sometimes.
Yeah. And I actually have had 2 patients report that their physician told them they just weren't pregnant long enough. No. But I say to patients, when physicians kind of jump on me about one thing or another, I say, okay, here's your assignment for the next month or 2 months or 6 months. Every time you see an endometriosis patient in the office that you have treated, you should be asking some questions like, are you able to attend your children's events at school? Are you able to keep your commitment to family activities? And are you able to participate in holiday celebrations, or are you just avoiding them? Are you able to retire your heating pad in the couch?
Yeah.
Are you able to return to intimate relations? And if the answer to those questions are no, you haven't done enough for that patient.
That's good.
Yeah, that's really good.
Yeah.
And I've written on that a few times, and I will continue to hammering that because all the physicians have to do is ask the patients a few quality of life questions to know how well they're doing.
Right.
And believe them. I think that's the other factor of that. You can ask the questions, but if you don't believe what the patient tells you, don't bother.
Right.
Because the patient will tell you honestly what's going on. One of the things that I've done about promotion of the movie Below the Belt is to my friends and colleagues and people who follow me on Facebook, I've said, think about attending the movie. Think about seeing the documentary. And the reason I say that to you is 1 in 10 patients have this, or people have this disorder. And you very likely have friends, family, colleagues at work, people in volunteer groups you may work with who are suffering silently and could use the support.
Yeah.
of your understanding what they're dealing with.
Mhm.
Absolutely.
Look at it from that way. It doesn't matter if you don't have it, but look
Right.
at the movie,
Mhm.
see the documentary, and then figure out, do I have some people around that need some support?
Yeah.
Mhm.
I mean,
Yeah.
I've always said endometriosis is not a terminal disease, but despair can be.
Absolutely.
And it's critical to know when people need support
Mhm.
and maybe need education to find other ways to cope with what they're coping with. Not everybody can access excision because of the cost, insurance, travel. Who knows what all the issues
Right.
are?
Right.
But they can use support. They can always use some.
Absolutely.
Mhm.
Absolutely.
Yep.
Well, thank you so much, Nancy, for
You're
taking
going to shut me
time.
up now, are
No,
you?
we love it. We actually would love to have you on again because I feel like you have
We
such
could
a
just talk
we could talk
forever.
forever.
I'm happy to help anytime. I've done this a number of times. I usually am not as messed up trying to get signed on, but
No,
but
it was
yeah,
us. Yeah, no, you're good.
I'm happy to do that anytime. I feel it's so important. I keep telling patients, you have to keep telling your experience. You have to keep
Have to.
your journey out there, because if doctors don't understand that what they're doing isn't helping,
Mhm.
then you need either another doctor or a doctor who can hear that what they're doing isn't helping.
Yep.
You need help.
Yeah.
And so, yes, I'm happy to do this anytime that it's helpful.
You are the
Yes.
best
Thank
ever.
you so much
I
for
think-
your time.
I think
Now,
this we are at the forefront of what's going to happen, and I truly believe that
Mhm.
that we have a lot left to do, but it's rolling. The wheels are rolling on endometriosis, and hopefully we can continue the wheels rolling in the right direction.
yeah, I think that's important. People say, well, nothing's happening. Well, I go back 30 years, nothing was happening.
Lots
There were a couple of
happening now.
doctors had done some excision, and they didn't have a complete understanding of what needed to be done, but they were
Mhm.
trying.
Yep.
And if I look at what was going on then, what Dr. Redwine brought to the industry and how that has altered practice across the 30 years, we've made significant progress.
Yeah.
There was a professor from Stanford had moved to Bend at the time, and he was looking over Dr. Redwine's research, and he was shaking the papers in my face, and he said, "This is really good stuff." He said, "But what you don't understand, it's going to take 30 years for this to be applied." What I didn't understand, I understood that, but what I didn't understand was it will probably take another 30 to be completely, taken in by the industry. I thought the industry would be transformed in 30 years. It's coming, and it is now coming at a much faster pace than ever before.
Yep.
So I think it's a time to be encouraged.
Yep.
Yeah, absolutely. Well, thank you so much, and we appreciate it. And we're going to have you back on because
Anytime I can help, I'm happy to.
you're great.
Yes.
And I just want to sit down and have conversation and have like a coffee or drink with you because you're so fun.
Yes.
I wish everyone
Well,
could.
it's too bad that
They're
I
so
wasn't
fun.
able to go to AHL this year in Denver. We could have met or something.
I
Yes.
know. We would love that. Well, we're going to be in
But I
Orlando.
couldn't make it this year. I'm going to try to go next year, but I think I don't know where it is. It might be in Kansas. I'm not sure where it is next year.
Kansas
I'm going to try to
close.
go.
It's close. Thank you so much.
Thank you so much.
All right.